At the ASCO annual meeting 2013, there were, among others, two papers presented on metastatic colorectal cancer and the discussion about maintenance or non-maintenance therapy. We're here with Professor Fortunato Cerdiello from Naples, Italy, to see if it's a discussion that's worth taking about changing the practice before having real evidence of the results of this approach.
The issue of the length of treatment in first-line metastatic colorectal cancer is still an open issue. Usually patients are treated until they get the best response from the treatment with usually chemotherapy alone or in combination with biologic agents, and a variety of approaches are done afterwards. Most of patients stop treatment between 5 and 6 months for having an interval free of treatment before eventually new treatments. In some cases, patients are treated with the so-called maintenance therapy. That can be either maintaining one of the components of the regimen that's being used in first line, or to switch to a different drug. Several approaches have been explored in different clinical trials in the past few years to understand which is the best treatment choice for these patients, and there's still an open question on the duration of first-line treatment and of the meaning of maintaining some of these drugs for as long as the patient progresses eventually. Two studies, both randomized phase 3 trials, were presented here at the ASCO meeting this year, trying to address this issue related to the role of bevacizumab, a monoclonal antibody against VEGF-A, in the maintenance setting. One study was by the Dutch colorectal cancer group, and another study was by the Swiss colorectal cancer group. Both studies were using a similar approach for the first-line treatment. There was a combination of chemotherapy containing oxaliplatin and fluoropyrimidine, such as capecitabine, for a given fixed time, and then followed by either maintaining bevacizumab alone versus no treatment, the Swiss trial, or by stopping treatment or maintaining capecitabine plus bevacizumab for the Dutch trial. In both trials, there were interesting results that were in some way suggesting that maintenance therapy can have an effect in prolonging the interval of disease-free for the patient, and this has been more pronounced and more statistically robust for the Dutch trial versus the Swiss trial. That was done in a little different way in terms of methodology. The Dutch trial also suggested a potential advantage in survival by using the maintenance versus no maintenance, whereas this was not conclusive for the Swiss trial. So therefore, at the end of these two very important trials, maybe we were even more confused than before, and at least for the general patient population that achieved a good response after a given time of treatment with first line, there is the option of trying to maintain with a maintenance treatment, and bevacizumab alone or bevacizumab in combination with capecitabine are good options with a relatively good ratio between the side effects, toxicity, and the benefit for the patient. Although this cannot be considered a practice-changing result.
Thank you.